Well, thank you everyone for joining us. Hi, I'm Krista Sineski. I'm the Vice President of Marketing with EloQuest Healthcare, and we're so pleased to have you here today for the concluding session of this Wednesday workshop series, Growing a Vascular Access Specialty Team, One Step at a Time. If you've been following along with this series, you know that in this format, we hope to help you improve outcomes in your facilities by sharing information and resources from trusted clinical experts. Today is the third in our three-part series and is all about ongoing evaluation. We are once again going to be joined by vascular access expert Lee Steer. Before I turn it over to Lee, there are a couple of just notes to address about our platform. First of all, asking questions of our presenter. If you have any questions for Lee, you can go ahead and type those into your control panel. They can be submitted at any time throughout his presentation. We'll address as many as we can in our limited time today. If we don't get to all of them verbally, we will pass them along to Lee and he will get you a response, which we can send back to you via email. Also, there will be two audience poll questions that Lee has prepared as part of his presentation. So when you see those pop up on your screen, be sure to interact with those and we'll all get to see the results when the poll closes. And finally, take a look at the handout section in your control panel. There are a couple of really great resources that you can download. First of all, there's a handy vascular access device site point prevalence audit tool, as well as an information sheet that goes along with that. Also included is a list of CPT billing codes, which Lee's going to be talking a little bit about in this presentation today. It's also been a very popular question that's come up in prior sessions, so please make sure you download that as well. And now to introduce our presenter, Lee Steer has been leading and growing the IV team at Hartford Hospital for about 20 years. At his facility, all PIVs are inserted on inpatient units by the VAST team using a bundled approach. Lee has spoken at many local and national vascular access conferences on CLABSI prevention, CVAD occlusion management, as well as PIV insertion using a vascular access specialist and a bundled approach. Lee is a member of the hospital's HAI committee and is the chair of the Hartford Healthcare Patient Care Clinical Value Team. He's the author of multiple peer-reviewed publications and is the principal investigator of an ongoing randomized controlled trial, which he'll share a little bit about with you today in today's session. So please join me in welcoming back our Wednesday workshop presenter, Lee Steer.
Hello, everybody, and thank you again for having me. Thank Krista. I appreciate the great introduction and what a great way to present information in a very short little format. So again, thank you for joining me. Good afternoon if you're on the East Coast, and if you're on the West Coast, good morning. So we're going to get right into this with some learning objectives. We're going to be on step 3, ongoing evaluation. We're going to look at 4 additional ways to improve and streamline IV therapy. We're going to talk a little bit about really, knowing your cost and value to stay on budget, and when do you request a budget increase. We're going to talk about publishing, collecting data and how important that is, how to speak the language of the C-suite folks, and then I'll show you at the end other tasks that we've been able to take on since our team has expanded in size and how it supports our balanced scorecard goals. So anybody who knows anything about sustainment, especially in healthcare, it is very challenging. So I thought, I did a little research, and a lot of stuff was posted on the IHI website, especially from the Chief Innovation and Education Officer who wrote these 2 things. And why does it matter? And the bottom line is that a system has to make a choice to be high performing. We hear a lot about high reliability organizations, and those are the type of organizations that institute some of these mechanisms that you'll see later in order to sustain interventions that they've done. Why is it so hard to sustain improvement? Well, there's just a lot of pressures going on today. If you think about, healthcare, especially post-pandemic, we have a nursing shortage, we have supply chain issues. There's just all of those make it much more difficult for sustainment to occur. One of my Cheryl Ficara, she's our Harvard Healthcare Senior Vice President of Operations for the Harvard region. She was actually my CNO for a while, VP, because she was a VP of the Chief Nursing Officer for Harvard Healthcare, but she stepped up her role a little bit. But I'll never forget her saying, it really is about leadership. And she always would say this to us: in order to be able to lead a successful team, you need to know your people. And I thought down below was pretty a nice little quote from Ian Gordon, former president of administrative operations at Elara Caring, just in the fact that first line management is probably the hardest worked and most undervalued level of management in any company. And I probably would say I would agree with that. I'm still here though and still enjoying what I'm doing, but it's very important for us to really be in close contact with our frontline staff, because we need to be able to hear what these people have to say, because they know best. And those are just some of the key. I think leadership is very key in any type of sustainment of any interventions that you put in place. So even interestingly, on the IHI website, they talked about some of the tips for actually facilitating sustainment. And it was very nice to see that a lot of the stuff we are already doing here at Harvard Hospital. In my prior sessions, I've talked about, since my team and I have taken over all the PIV insertions in the hospital on the inpatient units, we had to make some standard work around that. What that does is it makes sure that my staff know exactly what they're due to when they get here to right when they're at the end of the day handing off to staff. It really breaks things down step by step, talks about our goals and further goals of our standardization, and kind of gives you a little bit of a time limit and some of the tools that you need to get there. So we have a standard work document for this. We have standard work for assessing a central venous catheter that's malpositioned. We also have a standard work around CVC rounding, and anything that we find we continue to take on, we will always make another standard work document for that to assure that we're all following the same workflow. Another one is visual management system. So in prior discussions that I've had, I've talked about how we huddle twice a day, once at 7 a.m. and once at 7 p.m. This is all part of communication, which was actually another tip for facilitating sustainment. So this is where we start our day. This is not my team, by the way, but I thought it was just a good depiction of the team surrounding the huddle board and going over their daily playbook of how they're going to get through their day based on who's here, what volume they have. There's recognition, important hospital or departmental announcements, and then everybody has their individual drivers based on what they need to be watching out on their unit. For us, my team, we have central line rounding, where we really try to achieve a 75% goal when we print off our new sheets on Tuesday, Thursday, and Sunday. And then our productivity is a big one, and we'll talk a little bit more about that going forward. And then hand hygiene compliance is another one. Probably change that one soon, just because we seem to be 100% consistently. And again, this is where we review new ideas. This is where the staff get to speak. This is where they have their voice. They have their voice in many other forums. Trust me, they can email me, they can text me, but this is where, as a group, we get to discuss things and make sure that everybody, again, is on the same page. We also have a place where we can start doing standard work observations, which is very important to sustainment. And that takes a little bit more time, just because you're actually taking somebody and walking around with another person to make sure that they're following each step that needs to go. And again, this is also where we do a lot of learning moments. Some are very spontaneous, but we do have a 52 repeating educational sessions that we're incorporating into our daily management board. One more, accountability towards standard work. And how do we do that? Unfortunately, the only tool that I really have to make sure is standard work observations, but mainly it's the productivity index that I have, which changes biweekly with payroll. So our target set by the hospital is 98% productivity. And when we drop, I post it on the huddle board. Then we create a Pareto chart. Why do we think that our numbers have dropped? And then we put in some countermeasures to get that number back up. So for example, one of the things that we did take a pretty good drop recently, and it was related a lot to a new product that we brought into the hospital. So there was a lot of education going on. I had a bunch of staff on because I knew I was going to have to take staff out of the count, and I was able to cost shift those hours. But what it did is it made my productivity index drop quite a bit. And we get this, I get a report, an orders completed report every single Monday, and our average is anywhere from 975 to 1,050 orders completed weekly. Now, these are orders that I cannot bill for, but what we did is we were able to fold it into our productivity index because everything that we do in IV therapy takes a lot of time. So this is how right now I keep my staff accountable towards the interventions that we put in place and sustaining our standard work. So looking for opportunities to grow further. I'm always on this. You know, my staff sometimes laugh at me because I joke with them. I said, listen, if they asked me to put on fecal bags, I'd probably have you guys doing them just because it would help us get more FTEs and more money. I will never do that. But, you know, it's kind of a running joke in my department, but we're always looking for opportunities to continue our growth. And as you can see, you know, in 2015, we had 7 RNs and 2 LPNs, and our current state is 30, and sorry, that's wrong, it's 32 RNs, and I promoted 3 to clinical nurse leaders, and that's about where our FTs are at 25.65. This is my philosophy, and I'm sure everybody, a lot of other people share this with me. But I always, and I say this to my staff all the time, it probably frustrates them a little bit because it's hard work for a little while. And then once we can prove that we have new opportunities and we're showing new growth, that's when I ask for FTEs. So I always take on the task, see how it affects the department, get our productivity index, and then I ask for more FTEs once I've proven that. And it, again, you know, I've talked about this in past lectures, knowing your billable CPT codes and pushing to get them to use is so important. You got to make sure that revenue that you're producing flows to the IV therapy cost center. One of the questions I got recently was about, you know, DRGs, and they've heard that, you know, a lot of these CPT billable codes, what they just get wrapped up into a DRG bundle. And what I've always learned from talking with my CFO and my CNO is that even though, yes, my revenue budget is 26 million, we're probably not bringing in that much or getting paid back that much. But what it also does is it gives the hospital opportunities when they have to go renegotiate contracts with their payers to get more money because they're showing that the cost of care is a little bit higher. So one of the things that I'm going to be working on very shortly with my team is taking on a new CPT code for TPA administration. Right now, we just assess and then we order. So in order to capture that additional revenue, and it comes out to about, I think I calculated about 50 to 60,000 additional dollars a year. Again, it's more revenue. It's just another great opportunity. So always looking for opportunities to grow. So this is what we're using for billable CPT codes here at Hartford Hospital. These were right from our Epic website with a few blockouts. As you can see, those are inactive codes right now. But, you know, the CPT 36,000 for an IV insert, and then 76937 if you're going to be using ultrasound guidance. There's one for PICC lines, a lot for blood draws. And then you can actually bill for products or in supplies, and it really depends on if it meets certain criteria. And one of them is that you know, it's just that it has to be a single patient use item. So if you're putting in a PICC line, you're not going to be putting it in another person afterwards. So you get to actually charge that patient for that product. PICC and midline insertion. Currently, we're working to make new ultrasound. We have a bunch of new ultrasound machines. So we're currently working with our biomed to get the ability to download an image so that we can start billing using this CPT code for our PIV insertions. And I have actually calculated that because of the number of times we use our ultrasound, we're looking at a possible increase of about $4 million of revenue per year. So I'm really pushing hard to get that in there as well. And again, what are we doing? Just showing value to our organizations. Unfortunately, you know, our PICC line charging is probably going down because our PICC line insertions are down a little bit, with our midline insertions going up. And unfortunately, there is no midline CPT code. So when inserting a midline, you have to use a PIV insertion. And then if you draw any blood off of that, you can use that as well. So definitely a little less revenue, but you know, it is what it is. We cannot make up a CPT code. That's right from CMS, or Centers for Medicare Services. So when looking for opportunities, I really highly suggest, and I know I've said this multiple times, and if anybody's watched me, knows me very well, always look for waste, variabilities, and defects that you can control. These were patients that were admitted to our PIV5 right study, and as you can see, this is just a mess. If I could say it any way different, you know, the only thing consistent with all these IV sites is they're in a point of flexion. But everything else is different. You know, one of them doesn't have a dressing on it, one has an EMS site dressing, blood and tubing, different needleless connectors. So those are things that me and my team can control. And let's face the facts, administrators want evidence-based practice. We just need to show them where that is not occurring. So these are the pictures, the same exact patients that I just showed you earlier, with an evidence-based bundle used for the PIV insertion. So I always say this to people: when I went to go to my CNO after the study to ask for an increase in FTs and the ability to take over all of IV therapy, my meeting first was about for a half an hour, got cut to 15 minutes. And then when I got down there, I was waiting for her for 10 more, so I got 5 minutes. And when I went in, all she said to me was, "How many FTs do you need?" And I said, "Well, whoa, hey, on, you know, why are you so quick to make a decision like that?" She said, "I saw the pictures." So pictures say 1,000 words. You know, she did not realize the amount of waste that was out there. And once I showed her what, you know, what a good evidence-based PIV insertion could look like, this is where was really helpful for us in that. So poll question number 1, have you published your work?
Okay, and the results are in. Let's see, it looks like the majority does not even know where to begin.
Okay.
13% are published.
How many, what was the percentage?
I'm sorry, 13% are published, 32% are not yet but interested, and 55% just don't even know where to begin.
Okay, and I can totally appreciate the 55% who don't, you know where to begin. It's not an easy process, but there are great resources out there. Please, folks, reach out to me if you're interested in publishing, and I will be glad to share, because it is very important. And why is it important? You know, peer-to-peer sharing. I mean, I've learned so much more. I learn so much when I go to a conference, just sitting down and talking with people. Obviously, there's always great, you know, vendor presentations and everything else. But when I actually sit down with people and get conversations going, that's where I learn most of my stuff. Obviously, if you publish, you will have a sense of pride and accomplishment in showing your work. It puts your healthcare facility and team on the map, opens up tons of opportunities to share your work in other forums, you know, such as speaking engagements. I know that the Infusion Nurses Society uses peer-reviewed publications to write their new standards. They're going to be doing that, I believe, every 3 years now. And let's just face it, every CNO will, and they may not admit it, but they love when their nurses publish, because you know who's publishing most in a healthcare facility? That's providers. So they love it when nursing does it. And it obviously opens up other opportunities, i.e. independent consulting. And the bottom line, it is great for our specialty, and we really do need the research to be able to improve and to be able to increase and grow our teams. And I like this little quote by Sylvia Plath, who's a famous poet: "Nothing stinks like a pile of unpublished writing." And I must say, I agree. So, and it's also good to publish to show sustainment. So when we were doing our TPA reduction program here, looking at, you know, decreasing that through better central venous catheter assessments, that was published, the original article, back in, I believe, 2018. So this one we published in 2021, and basically was a 5-year look back called the CLEAR study at our lean central venous catheter management interventions. And you know what we had shown is that we still have achieved and sustained a nice decrease in our TPA between a time period of 2014-2020. A matter of fact, a 71.3 reduction in the TPA usage, as well as a decrease in the annual use of the TKO 6P anti-reflux needles connector of 41%. And then with our 5-year cost savings for these two expenses was estimated to be over 356,000. Again, CNOs love to see this stuff published. You know, we decided that it would be a good thing to look at, just to show that sustainment is a possibility, and we showed that through that. So we talk a lot about looking forward. You know, how do we keep finding more interventions to do? Again, we just got to keep looking at the data, demonstrating your value. Data, and more data. And my Edward Demings, I love him. In God we trust, all this must bring data, and without data, you're just another person with opinion. And I always tell people, I was that guy at one point in my time where I just had an opinion. My opinion was we needed to have an IV team here, and I wanted it. But as my CNO told me, come back with the data and we'll talk then. So again, always make sure that you really do focus on collecting data that reduces waste, variability, costs, and adverse outcomes. And then assuring that you're linking those improvements to the C-suite's balanced scorecard. And what are they looking at? These are the features for our balanced scorecard here. Improve patient customer experience. So obviously, if I can show that our patients are getting less needle sticks, that will help improve that. Provide safe and high quality care. We have specialists doing an invasive procedure on patients, so that helps with that. We do it safely. We do yearly annual revalidation. So we're always making sure we're top notch. More access to timely care, ensure financial health. Well, again, financial health is looking for opportunities, bring in a revenue, but also looking for opportunities to reduce any waste, variability, defects. And then, of course, a lot of hospitals now are starting to look at cultures of, looking at disparity, racial equity, and things like that. So, and obviously, we put in a line in anybody that needs it. So, and these are the ways that I link this stuff to our balanced scorecard. So by having a specialist team, we put in all the IVs in, we do have that opportunity to decrease that length of stay without medication, delays being given. We're obviously, hopefully resulting in less infections, less adverse events. We keep an eye on that. Our cost reduction, if we're putting in less IVs, we're saving money in those areas. Reducing CLABSIs, we're saving money there, and of course, patient and nurse satisfaction, which we talked about earlier in some of the surveys that we've done. So again, very important, speak the C-suite language. If you are saving time, you are showing them that you are saving money. So, and how important right now is nursing time these days? With our nursing shortages, different models of cares are being talked about. People are changing how they're doing things. For instance, at one of our facilities, because we want to try to have this, what we're doing here at Hartford in an IV perspective, we're trying to actually replicate that in all our sister organizations that are a little bit smaller. So one of the smaller hospitals, we actually trained the respiratory therapists to put in IVs with ultrasound guidance, and they really took it on and are really enjoying it. And the nursing time that's being saved is great over there. So just that's what C-suite folks want to do. They want to hear that you're saving money, proving outcomes and such, and you will get to them eventually. So poll question number 2 at your facility: what C-suite goals are most important to link to quality improvement project outcomes?
Okay, closing out the poll. And Lee, I don't know if you can see this on your screen, so I'll read the responses out to you, but we have nearly everyone has said, 86% have said reduce infections.
Yep.
And then 83% both said cost reduction, and 83% also said patient experience. Behind that, we have 71% reduced length of stay, and 48% nursing efficiency.
Good, very interesting, very interesting. Great question, and really what a great spread of of what people are choosing for answers to say. So clearly people get it. What is your C-suite looking for? And they're demonstrating the fact that what do we link to that? So we talked a little bit about, publishing, doing research. I haven't talked so much about doing research, but, part of doing research, of course, at the end is making sure that you publish your work. So my team's next study, which we're currently working on, is our journey for the perfect PIV insertion bundle. So this is another smaller RCT of 106 patients that we're going to do. And one of the things that we looked at with our first study, the PIV 5 rights, was where were our failure modes? And what we found was that, there were many times we had to go up and change patients' dressings before the 7th day. In turn to changing the dressing, did that, manipulate the catheter? That caused inflammation in the vein that could have led to early failure. So we've decided that in our bundle, we're going to add gum mastic for mastosol with every catheter that we insert, and we are going to use a different catheter that we feel is a little bit softer and hopefully will float a little bit more in the center of the vein. It's one that you use a AST type of technique for insertion. So I don't know who's going to AVA this fall, but my abstract was accepted for presentation. So I do hope to have a good portion of preliminary data for everybody when we're there in Portland, Oregon in October. And just so you know, on October 14th, it's the first day of AVA and it's my birthday. So won't be presenting on that day, but we'll have some fun together. So with the growth of a team, what else? So it's again showing value. So over the years, we have just continued to grow, and as we grow, we take on a little bit more. Some things we take on and then we ask for FTEs. Some we're able to just fold into what we are currently doing because it's something we were doing a little bit prior to help increase our productivity index. So one of them, care and maintenance of all CVCs outside of the ICU setting. Prior to us taking over all IV insertions, we were only doing central line care on PICCs and midlines outside of the ICU setting. So now we, again, round on all CVCs, a few times a week, and we make sure that we are doing the maintenance on every single one, right down to dialysis catheters if they're due when the patient doesn't go to dialysis center. We do Dobhoff tube insertions for feeding patients using real-time tracing technology. That helps avoid inadvertent lung cannulation that could result in pneumothorax. We actually recently took over all CVC removals. What we had found is we would find central venous catheters that could be removed. We'd notify the doctor. Doctor would say, okay, great, I'll get it out. I agree with you. Next day we'd come in, patient would still have their central venous catheter in place, and we'd reach out to the doctor, and the doctor would, well, I just got too busy and I couldn't get up to that patient. So I said, no way, that's unacceptable. We're going to take over removal of every single one, except for tunneled catheters. And we do use our transplant team to help us with the dialysis, because sometimes you can remove a dialysis catheter and have to sit there for 15, 30 minutes with direct manual pressure to create hemostasis. We now, this year, took on a station at competency stay. So every single month, nurses have to go to an area and get checked off that they've been revalidated on certain high-risk tasks. We were granted a booth over there, so we've been doing that on a monthly basis. We did all the monoclonal antibody infusions when COVID was happening, which was a great revenue for us and a great way to, again, show value and to show support for the pandemic that was going on. And many of you know, we're still continuing to grow our outpatient infusion business. It just keeps getting bigger and bigger. And very profitable for the hospital. So it's just, again, a huge way to show a value, which allows us to grow our team further. So this is a free resource. This is actually a template of a vascular access dressing change point prevalence assessment tool that Eliquis will use when they come into your organization if you call them and ask for their assistance. I find Eliquis to be very valuable. My rep, she'll come in a week in a week's notice and help me around on every single patient. She's much shorter than me, but I have long legs, but she keeps up. And she's just very enthusiastic, very excited about it. By the time I present that gift, she walks out with that information. Within a few days, she has it for me in a nice graph and a nice format. So I highly encourage all of you, please reach out to your vendors. They want to help. Okay, they're not just there to sell a product. Of course, they want to make money like we all do, but they want to help. They want to find and contribute to positive patient outcomes. So again, I would like to thank all of you for being present today. And if you were present in the other two sessions, I've appreciated the feedback that you've given me. The questions have been great. And if you have any more, I'll answer them now. If I can't answer them, I will absolutely make sure that I answer them via email, and Krista and Stephanie will make sure they get them to you. So thanks again, everybody.
Thank you so much, Lee. Appreciate it, everyone. We do have some questions that are coming in, and if you have any more, please type them in. We have just time for a couple. We'll just jump right in. Lee, how have you been able to create collaboration between departments who insert VADs? We frequently get pushback from the ER and IR providers when we make recommendations.
Okay, so no, it's been a 20-year journey for me, and I've created great partnerships with everybody here. And I'll tell you, it hasn't been the easiest ride. I probably did the earliest with the IR department. And really what it was is, for me in my organization, the morale was just so low in the IV department when I first came in that they were sending patients to IR constantly. We rarely send patients to IR anymore. I will, if they call me and say, hey, can you look at a patient? We got a consult for, let us know. We run right up there. I really try to connect with, the leadership teams to really try to educate, show them outcomes, but it's not an easy thing. I do practice my leadership behaviors. We have 10 of them, whenever I'm speaking with somebody, but I always put it back to the patient mostly. If we're in, if we can't work collaboratively as departments in a hospital or any other healthcare setting, the ultimate person at the end of the day is the patient who suffers. And I always put it back to provide to departments that way, as well as always saying, if it was your loved one in the bed, would you want us to be sitting here, getting providing pushback over what we know is evidence-based and what is necessary for our patients. So.
Great, thank you. So do you have a medical director for your program? And if so, who?
I do not right now. I've kind of pushed for one a little bit, but it's just never happened. So right now I'm under the medicine division. All our divisions are divided up, neuro, cardiology. I'm under the medicine division, so I just report to a nursing director.
Wonderful. And we'll just answer, I know we're a little pressed for time, so we'll just answer maybe 2 more questions. Okay. And as Lee mentioned, we will address any additional questions that have come in, because we have received quite a few offline, and make sure those responses are routed back to the person who asked. Okay. So my next question for you, Lee, is how do you deal with pushback about placement of multiple PIVs?
That's another difficult one. I do a lot of education, especially with new hires who come into the hospital. I spend a lot of time with them, and we do talk about just in case IVs and that they're dangerous and they're prohibited. We get a lot of calls to say, hey, we need a second IV site in this patient because the meds are incompatible. We'll do our own little research and then go up to them and say, well, it's not that they're incompatible, there just wasn't enough research done on it to say that they're not compatible. Sometimes you just have to, usually we can negotiate and talk about it and get out of it. I think, again, just because we've been beating the same drum over and over the last 20 years, I think people are really starting to get it. But it's really just providing the evidence, showing them the standards, talking about how dangerous purple IVs are, talking about the mortality rate of a BSI. I always like killing people with facts, and that to me is what you can't argue with it. So.
Wonderful. And I guess this will be our last question to answer live. And it's about, I guess, billing of procedures. So does the billing of these procedures occur inpatient, outpatient, or both?
Both. Yes,
Okay.
we have a very our revenue is divided into our inpatient revenue and our outpatient revenue, so I can see on both sides of things. But you know, if we go into, let's say we get called to a CAT scan for a site or pre-op, you know, where patients just same day, those all are billed as an outpatient IV procedure.
Okay, wonderful. Well, as I said, we are out of our time limit for today. We very much appreciate your time, Lee, on sharing this today, as well as for the prior sessions. For those who are catching up, you can take a look at the screen and access the recordings for anything you may have missed. And again, I appreciate our audience for joining us throughout this series. Thank you so much for taking such interest, asking such great questions. We do have a survey, as Lee referred to, that you'll have come up on your screen as we close out the session. Please do provide some feedback with that. We very much appreciate your thoughts and responses, and it helps us improve these offerings for the future. So thank you very much and have a wonderful afternoon.
Thank you, everybody.